Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2025 Proposed Rules Part 4, MPFS. This is Part 4 of a 4-part series. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We'll respond to questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross, Lori Foley, Sarah Bowman, and Katie Croswell.
Thank you, Jennifer, and thank you everyone for joining us today. On July 31, CMS published in the Federal Register the 2025 Medicare Physician Fee Schedule Proposed Rule. It clocked in at 1,053 pages, and that is not including the numerous addenda that are published only on the CMS website. We have covered part of the rule in 2 prior webinars, and you see on your screen here the agenda from the July 31 webinar and the August 14 webinar, as well as the URL to access copies of the slides, as well as recordings of the presentations from these 2 webinars. But today we're going to cover the last 5 topics for the Medicare Physician Fee Schedule final proposed rule, excuse me. We're going to cover the quality payment program. Lori will dive into MIPS. I will discuss CMI request for information on the new proposed ambulatory specialty care model, as well as the changes proposed to the Medicare Shared Savings Program. Katie's going to talk about social determinants of health-related services, and Sarah's going to wrap up with the clinical laboratory fee schedule payment reductions. Of course, a not so gentle reminder that comments on the proposed rule are due on September 9th. Here we have a screenshot from my computer of the link on the Federal Register website to the proposed rule, and you see that green box down there that says submit a formal comment. It is as simple as clicking that box and either typing out your comment or attaching a file to submit your comments to CMS. I wish they would strike the word formal, because you can be very informal in making your comments, or you can go into a great deal of detail. But it is critical that we are weighing in as stakeholders on CMS's proposals. I checked this morning and it was well over 1,000 comments so far, but certainly there are more that can be added to the mix on a wide range of topics, several of which we're going to discuss today. So with that, Lori, let me turn it over to you to discuss the quality payment program proposals.
Great. Thank you, Martie. This is definitely a topic between this one and the CMMI proposal that you will cover after this, where there are a lot of opportunities to make comments. So definitely encourage individuals to do so. We'll spend a few minutes looking at MIPS for the proposed rule for 2025. So that would be the performance year 2025 and the payment year 2027. Remember, there's always that 2-year lag. And if I step back and look at all of the updates in an aggregate, at least related to traditional MIPS and leading into some of the MIPS value pathways, which we'll talk about as well. I kind of see this year as a cleanup effort where they are tidying up, where CMS is tidying up some areas where perhaps there have been through a process has been generated, but it hasn't been codified in the regulations. So as we talk through today, you'll hear about a couple of areas where they're just kind of tidying up what has been historically a process, but not a rule, where now they're proposing rules. And then definitely related to that comment section, there are a number of areas to dig into as we go through for that. So looking at data completeness, starting off with quality, remember that the MIPS the MIPS program has 4 quadrants. Quality is 30%, cost is 30%, improvement activities are 15%, and promoting interoperability is 25%. No changes. That has been in place for a number of years in the program. So for data completeness, the 2025 and 2026 performance years have been finalized in previous years' rulemaking. For 2027 and 2028, they are currently proposing to hold it at that 75%. In last year's rulemaking, they were proposing to increase that to 80%. So holding it at 75% gives everybody a little bit of flexibility for data issues and such as they're navigating through by not increasing that threshold on a proposed basis for these next 2 years. Hold in mind that 2027 will come back around to some predictions for that year that may change a little bit as we go along. There are currently 196 quality measures. They are proposing to add 9. 2 of those are patient-reported outcome measures, which gives some additional flexibility for those high priority measures and patient-centered measures to show progress and outcomes. They are making substantive changes to 66, or proposing to make changes to 66 of those measures in the inventory, and they're looking to remove 11 measures. So what you would want to be doing as we go through this process is look to see about those changes and those removals to see how they impact the measures that your group is currently reporting on or tracking for your providers. They also noted that this does not include QCDR measures because those are approved outside of rulemaking and therefore they're not included in any of these counts that we're talking about. So Marty, on the next slide, they did add some clarifications related to top-down measures. In specific, you'll go back one. There we go. They are proposing a flat benchmark methodology to subsets of topped-out measures. These include for those measures that are included as part of the Shared Savings Program, ACOs. Currently, the benchmarks are based on a single methodology that applies to all topped-out measures. And so this one is allowing some changes, particularly in measures with specialty subsets, that there are limited choices and a high percentage of top-out measures. So that kind of was compressing the opportunities available for certain types of providers in order to provide or identify measures that were applicable to their clinical practice that they could still report on and still gain the necessary points through that reporting category. The measures will be identified or proposed to be identified each year through the rulemaking process. So just like we're seeing right now through a proposed process and then finalized later in the year. But a key thing here is the available points for scoring. As long as a provider scores above 84%, the way that they are kind of categorizing it, that provider would be eligible for 1 to 1.9 points, up to 99.9% at 8 to 8.9. So if you notice, a provider can get 100% if they attain 10 points. If they get 100%, they attain 10 points. What's missing? 9.0 to 9.99. And they really want providers to strive for as aggressive as possible to perform as well as possible. And so they took out any awarding of 9 points. If you get up to 99.9, the highest you can get is 8.9. If you're perfect, then you can get 10. No path there to get 9.0 to 9.99. They are also adding a complex organizational adjustment. They are proposing to count for organizational complexities, particularly that are facing APM entities as they are navigating, and then virtual groups when they are trying to report ECQMs. That adds 1 achievement point for each submitted ECQM for these entities that meet that data completeness and case minimum requirements. So those are outlined in the individual quality measures, but that adjustment cannot exceed 10% of the total available achievement points in the quality metrics. Last note on this topic, CMS is also proposing that Medicare's CQMs are available only to Shared Savings Program ACOs that would be scored using flat benchmarks for measures for the new measures' first 2 performance periods. So they're building in a runway for those measures to have a benchmark as they come in and go available. So when we look at minimum criteria, this is one of those areas where I think they are, and we'll reference this, where they're doing some cleanup. If you read through the narrative and the conversation, it sounds like providers have been penalized if they have submitted anything related to certain criteria, even if that anything was just the practice name and the tax ID number. There were no numerators or denominators, for example. They submitted data, The data didn't meet, so they might have been penalized in that particular scenario. With this, they established minimum criteria that has to include that numerator and a denominator for at least one quality measure in order for it to be considered a valid data submission and thus be scored. And that, again, just is trying to hit, I think, or trying to clean up some scenarios where providers were penalized but didn't necessarily have an opportunity or a path to remediate that efficiently. They are also adding APP plus quality measure sets, optional for MIPS eligible clinicians, groups, and APMs, but it's required for those MSSP, which will be required to report the measure set. And we'll talk a little bit about the APP plus quality measure set that are required, but you see that they are including a phased-in addition of the 5 adult universal foundation measures, which is a little bit of a mouthful, over the next several years. And you see breast cancer screening, colorectal cancer screening are coming in 2025. Initiation and management of substance use disorder treatment in 2026, social drivers of health and adult immunization status in 2028. You know, when they look at that, they see that as an opportunity for, they're very clear as the path where they're looking for us to go. We know that the goal has been to eventually sunset traditional MIPS, move to MVPs so that they can have more relevant comparisons between providers. Martie will talk about the CMMI proposal that they have, which is intending to drive that even further. CMS has indicated through comments in this proposed rule that adding these adult universal foundation measures are just an avenue to help people get more familiar with them so that those transitions are a little bit smoother as they move on. Looking at the next slide, on multiple submissions, again, cleaning up some housekeeping, it sounds like providers through their reporting of quality have intentionally or inadvertently submitted multiple measures and or multiple submissions in the quality area, and they are trying to just be very clear on what's going to get scored, what's not going to get scored. So if a tax ID submits information and it comes from 2 different organizations, so for example, the practice submits through their EMR and then they also submit through a registry. 2 different organizations, one's coming from the tax ID, themselves, and then one from a third-party intermediary. CMS will calculate both scores and they will assign the higher one. If it's coming from within the same organization, and their examples are that you've got multiple practice managers and you've got 3 different practice managers, they all submit. The last one submitted will be the one that is scored, and that score will be applied. So it wouldn't be an assessment of which of the 3 is better. It would just be the last one submitted, and that score would carry. And so it's they do add the distinction because some providers do self-report through different paths. And in that situation, that would be, that is not subject to this multiple submission rule. Those would be scored individually and applied as appropriate. For the MVP population health measures, they're proposing to score all of the population health measures and apply the highest scoring. And we'll talk about MVPs in just a few minutes a little bit deeper, but recall that entities and organizations have to register for an MVP. When they register for that MVP, they are selecting which MIPS value pathway that they are selecting. And at the time of registration, they currently have to choose which population health measure that they want to be scored on. CMS is trying to make it easier for individuals to go the MVP route. And so rather than have somebody commit on the front end as to which measure that they would be scored on, they are proposing to score them all and then assign the highest value so that removes a barrier for adoption. So shifting now to cost, MIPS is adding 6 episode-based cost measures with a 20 episode case minimum. That 20 episode minimum is pretty consistent. One of those measures is an acute inpatient medical condition for respiratory infections. And then they're adding 5 chronic conditions as you see here. So chronic kidney disease, you see a theme there, chronic kidney disease, end-stage renal disease, kidney transplant management, and then 2 extras, one related to prostate cancer and the other related to rheumatoid arthritis. They are making significant updates to 2 existing measures related to cataract removal and inpatient PCIs. they're codifying removal criteria. So when would a cost measure be eliminated? So if that's a deep interest for you, something you can read a little bit further. But they are making substantive proposed revisions to the cost scoring methodology for this performance year, for 2024, the one that we are currently in. So if this goes through as proposed, it would be, I guess, sort of retroactively immediately effective for 2024 and how you are going to be scored for this current performance year. It's currently based on benchmark decile ranges and the corresponding percentiles for which the MIPS performance falls. They're proposing to change that to be a set median of 7.5, which is the current performance threshold equivalent. And then providers will be scored positively or negatively based on standard deviations from positive or negative from that 7.5. So a big shift in methodology. If you remember all the tables and your score falls here and you're in this decile, you get this many points. Now it would be a plus minus of, I think it was 0.5 to the positive, 2.5 to the negative. So depending on how you are ranked based on those standard deviations. So that will be something to look at and weigh in on if you have a concern related to that. There were on improvement activities, they always change the inventory each year. So this would be looking at 106 improvement activities, adding 2, modifying 2, and taking away 8. Again, codifying that removal criteria back in the housekeeping bucket. They are also proposing to remove the weighting. So if you recall right now, you've got in your improvement activities, each activity is either assigned a medium weight or a high weight, and you need a certain number of points. And so you need a different number of combinations of activities to get to those points. Again, they're trying to remove barriers and make it easier for providers to navigate, manage, and so they are proposing to remove those weightings. And then they are also proposing to remove the number of required activities. If you see here, if you are part of an MVP, you elect to go that route and register for that, then you are only required to report on 1 improvement activity. If you have a special status, which currently also allows providers to essentially navigate to half of the required points of a traditional provider, again, only 1 activity. And those special statuses are small groups, so providers with less than 15 clinicians, a provider that's in a HPSA health professional shortage area, in a rural area, or they're non-patient facing, then those providers only have to do 1 activity. And then all other traditional MIPS participants have to do 2 activities. So we mentioned at the onset, and we'll continue to talk through CMS's goal for providers to continue to transition to these MIPS value pathways as they come out. You see that they're adding these incentives by only requiring 1 activity to be participated in order to meet that measure. The minimum criteria must be able to add a yes response for at least 1 IA activity, again, cleaning up accidental submissions, and then the same criteria for those multiple submissions, again, codifying in the rules how exactly they will be handling those. Shifting to the promoting interoperability, the automatic reweighting, for 2024, clinical social workers are the only providers for which automatic reweighting of the PI category is occurring. In prior rulemaking, this was the last year for that to occur automatically. So they just note that they are not extending that for social workers. It will expire in 2025. That means that from a clinician type, there will no longer be any automatic reweighting. There will be the ability to continue automatic reweighting for certain special statuses, as you see here. So ASCs and hospital-based, non-patient facing, and small practices. There will be, again, minimum criteria required elements before they will score, again, adjusting for those accidental scoring situations. For multiple submissions, they will score everything that's submitted and they will apply the highest across the board. And then that subgroup reporting will continue, based on the existing policy that the subgroup is required to report the group. They can't segment promoting interoperability to the subgroup level, so it will continue to be tracked at the group level and applied across the board. Some changes that are being promoted for or proposed for final scoring. Historically, there was no reweighting policy to address when a third party did not submit data on behalf of a clinician in those circumstances where it was beyond the clinician's control. So they are, again, codifying that providers will have an opportunity to request reweighting where they can't get to the data or a third-party intermediary did not submit the data as the provider had intended. The providers delegated that to the third party, and the third party didn't get it submitted by deadline. Again, there wasn't a formal codified process to follow in those scenarios previously, so they were putting a path in place. You see here that CMS, it's not a carte blanche granting of that reweighting. CMS will look to see specific circumstances related to the agreement that the provider had in place with a third-party intermediary, what types of issues were identified, what the provider did to remediate those issues, and in fact that the issue itself caused the data to not be submitted. And in those scenarios, then the provider, the clinician, can submit for a reweighting consideration. That would be done by November 1st of the relevant payment year. So remember, if you're reporting now in 2024, our payment year would be 2026. So you would have to submit this, and this one has a calendar year 2024 performance period application if it passes or is codified. So you would have until November 1st of 2026 to bring forth this issue and this reconsideration in your plan for that particular payment year. A little bit of a nuance there. And at last but not least, on that final scoring, the performance threshold is proposed to continue to stay at the mean, which is currently 75 points for calendar year 2025 performance. So touching on the MVPs, there were, in comment as they continue to navigate the discussion. Again, we've talked about Medicare's goal to have practitioners eventually, ideally elect to transition to a MIPS value pathway and MVP program. And recall from prior conversations that the purpose of doing that is to narrow down the criteria that the providers are measuring themselves on so that they can make comparable comparisons. So that if I'm looking at a urologist, then I'm comparing urologists on the same criteria based on the specific measures for quality, promoting interoperability, improvement activities, and cost. Where right now providers can choose any, of the whole menu, they can choose any ones that apply, which lowered their ability to compare across specialties. Their goal is through the MIPS value pathways with what's proposed in 2025 is to have an MVP that fits 80% of eligible clinicians so that they could have a pathway to go down for those MVPs. They didn't put a year out there as to specifically when they want to sunset traditional MIPS. Earlier years in rulemaking, they had put 2027 as the year out there. They did add a bevy of new MVPs. They added 6 this year that pulled in a lot of specialties that were excluded or just weren't relevant for the prior MVPs. So they really are aggressively expanding that inventory to pick up specialists of all types in addition to primary care and a variety of and chronic conditions to capture a large number of providers so they can go through that MVP route. They did make modifications to 16 currently finalized MVPs. Most of those were adding a quality measure, adding an improvement activity, or deleting 1 or 2 of those. So if you are currently in an MVP or planning on one for next year, you need to just review that inventory to see those changes and how those impact you. And then they also proposed a consolidation of 2 neurology measures into 1. Again, really just looking to get that new model underway. I think they have identified some challenges for it and are looking for that group think. Martie, don't you think, as they put out that CMMI innovation, and they ask for a ton of questions and considerations as they go through really trying to navigate what that might look like.
Always good to click the unmute button. CMS, as you know, stands for Centers for Medicare and Medicaid services. Centers is plural. The physician fee schedule is developed and promulgated by the Center for Medicare. But the Center for Medicare is bound by the strictures of the Social Security Act. So any regulations they promulgate, any systems they develop, they are always bound by what's in the statute. And specifically with regard to MIPS and the Quality Payment Program, is those confines that were developed by MACRA back in 2015. So Center for Medicare walked next door to their colleagues in the Center for Medicare and Medicaid Innovation and proposed that we can use some of your authority to continue our work towards making MIPS more comprehensive, more logical, more meaningful. And CMMI apparently is up to the challenge, and as part of this year's proposed rule, the Center for Medicare has included a CMMI request for information. Now, why this is critical and why we involve CMMI is because of its unique statutory authority. CMMI was created as part of the Affordable Care Act to take over the role of development and implementation and evaluation of pilot programs within the Medicare and Medicaid program. Before CMMI existed, anytime we wanted to do a pilot project that varied the payment rules, you literally had to get an act of Congress. And so obviously a very slow, diligent process of trying to develop this up. But CMMI has the authority to try new things. So to effectively, erase the lines of the Social Security Act or provisions within the Social Security Act to try something different. And so in this RFI, CMMI is looking for input on what it refers to as the ambulatory specialty care model. When I first saw this headline in the proposed rule, I'm like, what is this? Or what are we going with a new payment model? But what it really comes down to at the end of the day, now talking and moving slides is really beyond me this morning. So just a second, there we go. It is MVPs 2.0. And really, is this a predictor of the future of MIPS? So what they are proposing, or what they're thinking about, not yet proposing, but thinking about and seeking your input, is to now adjust participating specialist payments based on their MVP performance relevant to all other participants in the same specialty or subspecialty. One of the challenges of MIPS and one of the statutory requirements within which CMS has to operate is the manner in which scores are calculated. And currently, there's just a single pool of all MIPS eligible clinicians from which we calculate the final MIPS score. And so, yeah, we're comparing different specialties, we're comparing different specialties within different measures, and we're comparing different methods of reporting. It's always sort of crazy to me that if you look at a particular quality measure, for example, there's 3 different benchmarks depending on how you report the data. So here the attempt is to start bringing order to the system. So if you are a neurosurgeon, you're going to be reporting on the same measures as other neurosurgeons, and then your score is going to be reflective of how you fall within the universe of eligible clinicians who are neurosurgeons. Certainly, it affords the consumer a far greater insight into the quality, the cost, the engagement of their particular specialists. Helps networks develop more reflective, high quality specialist providers. It helps primary care physicians identify who to send referrals to. So they really see this as a significant opportunity to take MIPS and really up to the next level. Now, and this is their way of accomplishing that, short of getting Congress to take action. And so it's a bit of a stretch, certainly, CMMI using its authority in this manner. And so that's part of what they're seeking feedback on. It's sort of not one of these bullet points, but certainly with written between the bullet points is, can we really do this without really making the industry very, very angry? And so if you are opposed to this approach, this is certainly an opportunity to expressed to CMMI that this would be potentially beyond the authority they've been given under their authorizing statute. But let's take a closer look at some of the items on which they are seeking input. And part is participant selection. They don't intend to roll this all out at once. They're not going to take every MVP they've developed up to this point, which is how many now? Lori, are they in the 30s almost at this point?
No, with the 16, they're about, they added 6, so we should be about 22.
Oh, okay, I'm way ahead of the game for them, but they're saying we're not going to roll out all 22 at once. We get that. That would be too much stress on the system. But how do we prioritize specialties? Where do we go first? And then the all important question, if we identify a specialty, should participation in MVP 2.0 be mandatory? And yes, CMMI interprets its authority under its authorizing legislation to say we can require everyone within a defined subgroup to participate in a particular alternative payment methodology, such as MVP 2.0. And so they're saying, should we take that? Because the issue is self-selection. And that's always a challenge that CMMI is trying to negotiate its way through with any of its proposed models, is that the folks most likely to say, raise their hands and say, yes, I'll participate, are those that are more engaged. And so would we in fact simply be scoring the very best of the best and leaving the others that don't even want to raise their hand because they're trying to, kind of under the radar screen? Should we let those folks get away with that? They're saying, no, should we effectively require everyone that has enrolled in Medicare within a certain specialty? So it comes back to your enrollment status with Medicare. Should we in fact require them to participate in this to give in fact the industry a much more accurate reading of how specialists compare with each other? They look for input on performance assessment. So should we weight the categories in the same manner as we've always weighted, or would there be a reweighting as part of MVP 2.0? They look to patient payment methodology, which is a question to the industry. How much is enough to get you to do something different? Either pay you more or penalize you more. But what's going to move the needle for these specialists? Are they going to be willing to take a bad score because of the work involved in using an MVP and the additional reporting requirements that are associated with that? Or is it simply the bright sunshine of transparency going to be sufficient that we are going to actually score specialists? Is that enough to get them engaged in this process as well? They want to consider, how do we promote partnerships with accountable care entities as well as primary care providers? Should we do surveying of primary care providers to get input and feedback on specialists? They look for anything on HIT and data sharing you want to express in comments, health equity, and then also multi-payer alignment. What are the opportunities to align this with MA plans, to align this with other commercial payers, to look at state Medicaid programs, so that we're getting an accurate picture across of what a specialist is actually doing. So it's a big kind of between the lines RFI. It's not, and when you read the proposed rule, it's nowhere near the discussion of MIPS. It's like in a whole several hundred pages separately. So something that really does need our attention, because given how quick they've moved with MIPS and MVPs, Lori.
The MVPs in particular, yep.
Exactly, they are ready to jump into this one and at least start a few specialists. So even if you're a specialty that doesn't want to be selected, it's probably a good opportunity to
weigh in. And Martie, we've talked, and I know we've talked to some hospital associations and some national organizations that have, I think, really pushed for MIPS to be MIPS, whether it's MVPs or traditional MIPS, to be gone, right? That it's not effective. It's creating a burden. It's not creating value. And I think this gives another indication that they're just they're doubling down, and MIPS is not going away, whether it's the 2.0 from an MVP perspective or even the 1.0 from an MVP perspective. I do think they're trying to make some pieces of it easier, trying to make it more meaningful for both the provider and the patient, but I don't see it sunsetting completely and it just being abolished.
And just a word of caution here. I mean, CMS always, despite what you may believe, CMS is always orienting itself towards the beneficiary and protecting the beneficiary. And so as a consumer, I think, this sounds great. I could actually look up my specialist and see how he or she compares. So as specialists and providers, if you have concerns about this, that would give a false picture, or there are other types of, I don't want to be ranked because of X, Y, or Z, because different specialists have different patient panels, for example, significantly, or specialists within a system versus independent specialists. This is the time to comment, because otherwise I think it's full steam ahead with CMMI, at least based on my reading of the tea leaves. Okay, so for MIPS, to everyone's favorite alternative payment model, or at least CMS's favorite alternative payment model, the Medicare Shared Savings Program. It's amazing to believe this has been around now for more than a decade. We have about, I think, 40% of traditional Medicare beneficiaries are now attributed to a Medicare Shared Savings Program, ACO. And as we've been saying for a long time now, CMS back in 2022 set the goal of having all traditional Medicare beneficiaries in an accountable care relationship by 2030. And last year, there were a number of modifications made to the MSSP, all of which were finalized and will become effective for performance year 2025, with the intent of improving and enhancing participation, specifically trying to reach out to safety net providers, rural providers, specialists, and getting them engaged in the process as well. This year, you'll see some follow-up on those themes as well. So starting with this new prepaid shared savings option. I guess getting a loan from CMS based on your prior participation, your credit score, shall we say, you are eligible to apply for prepaid shared savings option if you are participating in a level that involves some degree of risk. So if you're in level A or B, you only have upside risk, this is not an option for you. You again have to have that credit score that justifies CMS giving you this loan, meaning that you have a history as an ACO of meeting quality standards, not avoiding at-risk beneficiaries, and having earned shared savings. And it's sort of, I believe that they would include folks that did not actually get a check in the mail, but were somewhere between savings and their MLR. Or minimum MSR, minimum savings ratio. They would be potentially eligible for this as well. You will be required as an ACO to submit a supplemental application. That will be at this period in the summer between June and August when we're doing our participant updates and the like. That would be the time period in which you would submit the application. It would include a detailed spend plan, what you will do, what you intend to do with the money. And once you're approved in a performance period, you'll have to update that annually with CMS. The amount you would receive as prepaid shared savings is calculated using a detailed formula that I don't even pretend to understand, but it is looking at the number of beneficiaries you have, your historical performance and the like. It's going to be then paid out quarterly throughout the period, your performance period. How can you use the funds? Not to give everyone a check is the answer to this one. You are allowed to spend up to 100%, but at least 50% each year of your performance period on direct beneficiary services. What do they mean by direct beneficiary services? These are primarily addressing social determinants of health within your population. So transportation, food assistance, housing modifications, rent, air conditioning, refrigeration, you name it. Anything that you would provide to a beneficiary other than medical services covered by Medicare that would help improve their health. And so this is giving you the finances as an ACO to accomplish that with prepaid shared savings. You may spend up to 50% each year on staffing for your ACO, as well as other infrastructure such as IT systems that help you with your operations. The list of what you cannot spend this money on is lengthy. You cannot spend it on management or parent company profits. You can't write them a check for their services. No performance bonuses to ACO participants or ACO other entities. No provision, you cannot pay for Medicare covered services using this money. So you can't have a financial assistance policy and then reimburse yourself for those services using prepaid savings. No cash or gift cards to patients. So I kind of wonder, how do you do transportation? I guess you can give them an Uber voucher. Does that count? But okay, I'm getting way into the weeds there. Items or activities unrelated to ACO operations or beneficiary payment. And no surprise, you cannot use this to pay prior year's losses as reimbursement. Other thing to note, if you would pursue this opportunity, is that funds will have to be repaid if your future shared savings are not adequate to cover the total amount you were advanced. So if you're advanced 10 million and you only earn 9 million in shared savings, they'll treat that $1 million gap in the same manner it treats exceeding your benchmark. So it's effectively adding this amount that you take as pre-savings to your benchmark. because you will have the obligation to repay. You'll have to keep your repayment vehicle on current with CMS, excuse me. And note that CMS has included changes in the regulations on monitoring of ACOs to ensure ongoing monitoring of ACOs that have received prepaid shavings, and they will discontinue your quarterly payments if they find that you're out of compliance. Other changes CMS is proposing, and again, as Lori said, it's really housekeeping activities there, which they're engaging beyond this prepaid shared savings. The addition of a health equity benchmark adjustment. They use HEBA in the ACO REACH program, and they credit HEBA to increasing safety net provider participation. This is just an upward adjustment to a benchmark that's based on the proportion of your treated beneficiaries that are either enrolled in a Part D low income subsidy or are dually eligible for Medicare or Medicaid. Those are CMS's favorite criteria to use in trying to identify individuals with higher needs. So even though your benchmark is obviously adjusted or takes into consideration the higher cost of caring for these types of patients, they're going to give you yet another kick up in your benchmark because you have a population you serve that is in this higher risk area. It is not an automatic because you are going to get an upward adjustment for one of three potential adjustments, either HEBA or the previously promulgated positive regional adjustment or prior savings adjustment. With regard to quality measures, again, this aligns with what Lori just discussed, because remember, when an MSSP ACO reports on quality, it's reporting the quality measures to determine its percentage of shared savings, but it's also reporting the quality measures with respect to the MIPS score that ACO participants are going to receive. So again, this is going to align the use of the Universal Foundation measure set, moving towards reporting on APP beginning in 2025. Of note here is the discussion of ECQMs versus Medicare CQMs. As Lori noted, only ACOs can report the Medicare CQMs, which means you're only reporting on the universe of Medicare beneficiaries as opposed to all patients. ECQMs, all patients, how you report on the measure. Medicare CQMs, which were created to help alleviate the burden of ACOs moving towards CQM reporting, allows you to limit your reporting to Medicare beneficiaries only. They also have, they intend to eventually phase this out, but they haven't put a year on it yet, at least at this point. So probably good for 2025, 2026 on using the Medicare CQMs. Regarding improper payment adjustments, and there's two here to take into consideration. They intend to finalize a policy for making adjustments to both benchmarks and expenditures based on the identification of, I love this, significant, anomalous, and highly suspect billing activities. And the example they're citing, in fact, they've actually previously promulgated a proposed rule to impact 2024 that relates to a multi-billion-dollar catheter billing fraud that was in fact identified by MSSP ACOs. This was billing for catheters for folks that didn't have the right diagnosis, had never consented, you name it. There's just been this billing fraud, which was identified by ACOs that noticed these outlandish high levels of catheter bills within their spending limits. And so CMS is creating a process to make adjustments when they identify that level of fraud. They also are introducing or proposing adopting a new calculation methodology to account for the impact of improper payments in recalculating expenditures. So let's say ACO participant has found that they are obligated to repay X amount of money. They've internally identified an overpayment. They repay that amount. It's significant. It potentially could impact whether the ACO receives shared savings or not. So they're now creating a vehicle for when that should occur. An ACO having the ability to request a redetermination and recalculation based on those repayments of dollars to CMS. Other changes, very quickly, on the beneficiary notification of participation in an ACO, finally, they got rid of this very confusing rule that you have to provide the supplemental communication either within 180 days of providing the initial notification or the beneficiary's next primary care visit, whichever occurs first. how are you ever going to know when the beneficiary's next primary care visit is going to occur? So we finally got rid of that. So the supplemental notification occurs 180 days after the original notification. As is the case every year, they've revisited the CPT and HCPCS codes that qualify as primary care services for purposes of attribution. You see that the list of the new services they're going to continue. And finally, I think an interesting adjustment by CMS, the eligibility requirements. They are no longer going to terminate an ACO should it fall below 5,000 attributed beneficiaries. You still have to have 5,000 to get in the door, but they're no longer going to terminate you if you go below that number for some reason. The idea being that the MLR, MSR adjustments are sufficient to address that smaller universe of patients, and thus we don't need to be policing on a regular basis whether they continue to meet that criteria. So that's what's up in MSSP. I think this means the ball is going over to Katie to talk about SDOH-related services.
Thank you, Marty. Yeah, I'm going to talk really quick about CMS's request for information on SDOH services. As you may remember, last year, CMS finalized G codes to reflect new coding and payment for Community Health Integration Services, or CHI. And Marty, you can go to the next slide. Technology, thank you. Social Determinants of Health, SDOH, and Principal Illness Navigation Services, or PIN. And now this year, CMS is requesting feedback for additional policy refinements or other factors to consider. In the proposed rule, they bring up, any barriers to furnishing these services. They want to hear about it, the types of personnel performing these services, and are there any barriers to their training or certification requirements? Any related services that maybe are not described by the coding finalized in 2024, payment for these services and how to improve utilization in rural areas. Next slide. Are the services described by the codes allowing practitioners to better address unmet social needs that interfere with their ability to diagnose and treat patients? CMS is also really interested in hearing from community-based organizations, or CBOs, and their collaborative relationships with billing practitioners. As you may remember, PI and PIN services may be provided incident to the billing practitioner. And so CMS is seeking comment on whether that incident to billing construct is appropriate for CBOs. They're also seeking comment on the CBO's role, the extent to which practitioners are contracting with them, like I said before, incident to billing, and then practitioners serving in rural, tribal, or geographically isolated communities. They also want to hear from practitioners in geographically isolated communities like rural, tribal, island communities about coding Z codes on claims associated with billing for CHI, PIN, and SDOH. And for those of you that don't know, a Z code is an ICD-10 diagnosis code that identifies factors that influence the patient's health status. Next slide. Lastly, CMS is proposing to establish payment for SDOH risk assessments as part of intake activities with opioid use disorder treatment services, as long as they are medically necessary for the diagnosis or treatment of the opioid use disorder. Although the reimbursement for providing SDOH risk assessments was added last year, there is a recommended expansion to include the same add-on for OTP in the bundled intake. So CMS proposes updating the payment for intake activities billed with G2076 to include the value of the non-facility rate for the SDOH risk assessments billed with G0136. CMS stated in the proposed rule they believe G0136 serves as a reasonable proxy to reflect the value and resources required for this type of assessment. When OTPs bill for G2076, they're not proposing that the OTP perform the risk assessment in a particular manner or add additional criteria to the assessment. Rather, they're just saying to continue performing their initial assessment consistent with the SAMHSA requirements, which already reflect those SDOH risk assessment criteria. With that, I'm going to pass it on to Sarah, who's going to wrap us up with clinical lab fee schedule payment reductions.
Thank you, Katie. Marty, if we can go to the next slide, please. So to understand what's being proposed for 2025, I think we probably first need to do a really quick history lesson on how we got to this point with the clinical lab fee schedule and with PAMA. So PAMA, or Protecting Access to Medicare Act, was implemented back in 2014. Yes, I said 2014, 10 years ago, with an intent to preserve the Medicare physician fee schedule rates by reducing reimbursement for other services, including clinical lab services. So up until 2017, before PAMA was enacted and put into effect for the clinical lab fee schedule rates, those rates were fee schedule driven. They were geographically focused, state specific, somewhat similar to the Medicare physician fee schedule, and payment was generally the lesser of either the amount billed or that fee schedule specific rate that's geographically specific. And in some instances, a national limit may have been imposed on those services as well. So rates were kind of fee for service, what we're typically used to seeing within Medicare from a payment and reimbursement perspective. Rates were updated regularly for inflation based on the consumer price index. So in 2018, when PAMA came into effect for the clinical lab fee schedule services, not only did the reimbursement amounts that are being paid for the clinical lab fee schedule change, but the methodology of the rate setting changed as well. So rates were no longer set based on that geographic location or inflationary adjustments from a consumer price factor standpoint. Instead, payments were national. So every CPT code, every lab service had one specific reimbursement rate, and that rate was driven on an analysis of the weighted median of private payer rates and updated on every 3 years. So quite the shift from what we had previously seen for lab services historically. And because I said private payer rates, you may recall that that methodology also under PAMA introduced required reporting cycles, because Medicare had to get information from all of these various applicable laboratories on what their reimbursement rates currently were or are for private payers. So the data collection period initially was a January to June of 2016 data period. That was the data collection period. For our reporting period that occurred during the first quarter of 2017, so January through March. That first round of data collection was a little confusing. It was a little problematic, and so CMS continued to get comments during proposed rulemaking and implemented 2 changes in their 2019 rulemaking surrounding the definition of what constitutes an applicable laboratory. There was confusion among providers as to who was required to submit. So they took that feedback into account and excluded Medicare Advantage plan payments under Part C from the denominator of the Medicare revenues to enhance or broaden the number of labs that would qualify for the reporting. They also amended in 2019 the rulemaking to include hospital outreach labs that bill Medicare Part B, all of that with the intent to get a better and more representative sample of laboratories reporting, so that weighted median rate that they're paying for those lab services was a better representation of other labs across the country. So during this time, overall payment reduction amounts for lab services were capped at 10% in the aggregate. However, the specific CPT code level impacts for certain tests could vary, and we did see them vary quite a bit. Sometimes there were some large swings somewhere in the neighborhood of 15, 20, 25, sometimes even 30% initially for specific services. So the thought was that the reductions would be phased in with a 10% cap on reductions during the first 3 years of this cycle, so from 2018 to 2020. And then the next phase in was a 15% cap on clinical lab fee schedule reimbursement for the next 3 years thereafter. So it would have been from 2021 to 2023. Marty, let's go to the next slide, please. So I was speaking very much in past tense because if you've been paying attention to your lab reimbursement, you might be going, I didn't get that. That was not what we experienced. And that is because we continue to see a lot of legislative activity and congressional passing to delay all of this implementation and phased reimbursement reductions. So the 10% payment reduction cap did remain in effect in 2019 and 2020. But then starting in 2021, we began to see all sorts of delays on further reductions. And then Congress actually extended a freeze, so to speak, on clinical lab fee schedule payments from 2022 through 2024. Marty, if we can go to the next slide, please. So I talked about the annual reporting periods. This is where things get really interesting for laboratory providers. So as I mentioned, their rate setting included annual reporting and data collection periods. However, since 2019, Congress has again continued to pass legislation modifying those statutory requirements for this reporting. So we first saw that with the Further Consolidated Appropriations Act in 2020. That pushed reporting out a year. Then we saw additional amendments with the CARES Act in 2020. The CARES Act both delayed the reductions in reimbursement and also stated that in 2021, they were gonna kind of hold that reduction to say, okay, and there shouldn't be any reduction in 2021 as compared to 2020. At the end of 2021, we see the Protecting Medicare and American Farmers from Sequester Cuts Act. That just rolls right off the tongue. That shifted reporting so that there weren't not any reporting requirements from 2020 through the end of 2022. So that act said we're going to pick the reporting back up in 2023 and continue that for every 3 years thereafter. But because it failed to modify the data collection period that would apply, the next cycle continue to be based on a data collection period from 2019. So pretty old, a pretty old data subset that we're looking at and thinking about when we're thinking about how this is going to impact Medicare reimbursement across the country for lab services. In 2023, we see the Consolidated Appropriations Act, which delayed the reporting again 1 year. If you're still with me, you might be picking up on a theme. Everybody's just going to push the ball down just a little bit, just down one more year. So like the Protecting Medicare and American Farmers Act that I had mentioned, it again failed to address that data collection period. So we're still using pretty old information at this point. And then last but not least, I don't want to forget, we had the Further Continuing Appropriations and Other Extensions Act in November of 2023 to be effective for 2024. This further delayed the data reporting and the phase-in of payment reductions so that the data reporting would be required in January through March of 2025 rather than having any data reporting be due this year during calendar year 2024. So because of all of this activity, if you're still with me, we've only had 2 data collection periods and 1 reporting period during this entire time, so from 2018 till now. So it's a little bit challenging to estimate what the impact might be on future payment reductions under PAMA. The next required reporting period, assuming we don't have any other legislative changes that Congress passes, the next reporting period would be January 1st through March, so first quarter 2025. That would be based on a data collection time period of, drum roll, January through June of 2019. So we're still looking at pretty old data. The Further Continuing Appropriations and Other Extensions Act extended that payment reduction phase in process. So that 15% reduction would apply for 2025, 2026, and 2027 calendar years. Because of the repeated delays, we are now again trying to phase this in over the 3-year period. We're trying to get through that 15% reduction period because the 10% at this point has been fully implemented. As I mentioned before, that cap on reduction is based on aggregate lab fee schedule rates. So the reduction on a per CPT code basis could be variable, as we have seen it be variable in the past. However, some little maybe good news for providers is that when comparing the impact of a single code, the proposed rule, assuming it is final, would protect some of those reductions, so that on a single CPT code or service basis, you're not seeing a reduction of more than 15% when you're comparing it to the amount established for that code in the prior year. Some food for thought: in prior years, we've seen about 75% of services be reduced. When we look across the clinical lab fee schedule data set, if you will, the remaining 25% either saw an increase in reimbursement or didn't see any change. So it's going to be pretty interesting to see how this phased in reduction of payments actually plays out, understanding what the history has been in recent years. And then particularly because we are in an election year, it'll be interesting to see if this actually goes into effect next year and we see that 15% reduction, or if it continues to be delayed a little bit further. Maybe we'll be here next year talking about this. Martie, if you can take us to our next slide, please. So this is all for today's Healthcare Regulatory Roundup series. We hope that you will join us again in September. We will be talking about key provisions of the 2025 Inpatient Prospective Payment System final rule, as well as the end of Chevron. So stay tuned. Please join us. Thanks so much.
All right. Thanks to our presenters, Martie, Lori, Sarah, and Katie. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, slides and recordings for parts 1 through 3 of this series and every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any further questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.